Well, good morning, everyone, and thank you for joining us again on another proper wintry Thursday. We're really delighted to have all of you with us, and also delighted to have Dr. Thomas Marron with us today, who is the Assistant Director of Early Phase and Immunotherapy Trials, also a member of the Precision Immunology Institute at the Tisch Cancer Institute of the Icahn School of Medicine. Dr. Marron received his BA from the University of Virginia in biology and Italian literature, and then completed his MD and PhD at the Icahn School of Medicine, also completing his residency in medicine at the Icahn School and his fellowship and chief fellow year at the Icahn School. He also completed research fellowships at the National Cancer Institute, the University of Milan in Milan, Italy, Caltech, and finally completed his training with a postdoctoral fellowship, also at the Tisch Cancer Institute of the Icahn School of Medicine. And in the years since, in his really very, very promising career as a faculty member of our institution, has done so much to help us think about harnessing the power of the human immune system to improve the lives of patients, in particular struggling with thoracic and hepatic malignancies, thinking about how to optimize response rates to unitherapies and dual therapies, and also trying to prolong the duration of effect for any given therapy in the immune space. Dr. Marron is really leading us forward, as his talk would suggest today, in supporting these patients and improving their lives and improving the duration of those lives. So Dr. Marron, we're really thrilled to have you today, and welcome.
Thank you so much for having me. Today I want to do a little bit of an overview of cancer immunotherapy. I think this is one of the reasons why, as oncologists, we're having more and more connection with specialties throughout internal medicine and beyond. Primarily, unfortunately, because of the toxicities of these therapies, but these therapies have really revolutionized the way in which we are treating just about all types of cancer at this point, and it's really gratifying to see some of these responses. I'll talk a little bit about the toxicities, and I think that's something that is important to every medical professional to understand how to recognize and to know who to consult, because I know I have a speed dial full of nephrologists and pulmonologists that I now call on regularly. And then I'll talk a little bit, depending on how much time we have, about some of the work we're doing really to move the bar and to continue to increase the response rates that we're seeing. All right. These are my disclosures. Most importantly, I will be talking about just about everything I talk about is off-label. I'm a phase 1 doctor. I lead our phase 1 program here at Sinai, and so most of what I do is not FDA approved. And I will be talking about some clinical trials that involve research grants from Regeneron and BMS. Fortunately, the NCI does not pay for a lot of these things. Starting just with a gross overview, everyone on this call understands the different components of the immune system. But within the immune system, you know, there's a slew of different ways in which we're trying to harness the immune system to recognize and attack cancer. And we're using both the adaptive and innate immune system, whether it be through what we call in situ vaccines, you know, stimulating the myeloid compartment. Obviously, the B cell compartment is very important, particularly because we are using antibodies. Most of our therapies that I'm going to talk to you about, especially the FDA-approved medicines, are all antibodies. And all these antibodies, just about all the antibodies that we are looking at, are really about honing the T cell and natural killer cell response. So, you know, really increasing the ability of those cells to recognize and kill cancer cells. And, you know, within the immune system, there is a very delicate balance between activation of the immune system, recognizing, you know, foreign antigens and killing, you know, infected cells or cancerous cells, and tolerogenic mechanisms. And many of the pathways that we're altering are evolutionarily conserved, and they're very important for maintaining tolerance and not stimulating sort of an autoimmune-like picture. And the process of carcinogenesis, where, you know, people are smoking or sitting in the sun in Florida, is really about, you know, the accumulation of mutations that progressively result in, you know, normal cells looking more and more foreign. And as you guys can surmise from just basic biology, the mutations that accumulate in cells, particularly in smokers and in cancers that are related to carcinogens, result in an accumulation of mutations. Oftentimes there'll be thousands of mutations. Only certain of those mutations actually result in translation and transcription of mutant proteins, so mutant peptides that either are presented sort of in this bad schematic on the, or are proteins that are actually on the surface of the cell, so easily recognized by natural killer cells or antibodies, or more commonly, they are proteins that are intracellular, and then they're presented on MHC class 1 or class 2. And the problem is that, you know, oftentimes we will already have a pre-existing immune response. So your immune system has already been taught to recognize a neoantigen. In this case, this is sort of showing a neoantigen on the MHC class 1, which would be recognized by a CD8 T cell. However, the problem is that tumors have a variety of different ways that they have developed to turn off the immune response. The one that we think about most is the overexpression of PD-L1, which is basically a stop sign that even though the CD8 T cell has been taught to recognize the tumor, comes into the tumor, is about to kill the tumor cell, these stop signs, which PD-L1 is the one that we discuss the most commonly and that we actually have stains for, go up and basically make these T cells anergic. These T cells within the tumor are oftentimes called exhausted. And this is just a nice picture here on the right side. Oftentimes people think that, you know, most tumors are just devoid of immune cells. Actually, a lot of tumors, particularly lung cancers, if you take them out and you put them under the microscope, you actually will see that the tumor cells are a minority of the cells within the tumor. And the stroma and the immune infiltrate which exists, which oftentimes actually promotes a very immunosuppressive tumor immune microenvironment or milieu within the tumor, the immune cells are actually the majority, which really underscores the important role that the immune system plays in the potential for tumors to grow and eventually metastasize, and why we really need to focus on modulating the immune system within these tumors if we're ever going to have some sort of benefit. And everybody has heard of checkpoint blocking antibodies at this point. There's many reasons for this. One is the very nice story of Jimmy Carter, who was cured of his melanoma. It's not entirely clear how much of that was the immune therapy versus the radiation and surgery, but we think that it definitely played a role. It's also advertised on Monday Night Football. They have all these silly names that nobody can pronounce, but there's a lot of information out there. I think the advertisements commonly are a little bit misleading because, you know, everyone with lung cancer is running through fields with their grandchildren and living forever, which unfortunately for the majority of our patients is not the case. But as I mentioned, the tumor cells, not only are they, you know, turning off T cells, they are exerting lots of different immunosuppressive functions within the tumor. They're also recruiting a variety of myeloid cells and sort of differentiating T cells into T regulatory cells, which are also turning off the immune system. And so there's many different ways in which we can target the way in which the tumors are hijacking your immune system. And just to give you an idea of the complexity within the tumor immune microenvironment, this is showing your T cells. So your T cells, I always call, are sort of like your sentry cells. They're the soldiers within the immune system. Your antigen presenting cells, and particularly your professional antigen presenting cells like dendritic cells, are what I term the professor cells of the immune system. They're really there to tell the T cell whether to turn on or to turn off, and really exert both tolerogenic mechanisms and activating mechanisms within the immune system. And then there are the tumor cells, and as I mentioned, there's all these quote unquote bad guys. So these myeloid cells, macrophages, immature neutrophils, and T regulatory cells, which are kind of accomplices to the tumor and really turning off the immune system. And we have, within our phase 1 program, we have, you know, I think about 50 different clinical trials across all our different programs, looking at all sorts of different ways of modulating this delicate balance between activating and turning off the immune system. And most importantly, I'd say the majority of the agents that we're looking at are really focused here on the synapse between the T cells, the soldier cells of the immune system, and your antigen presenting cells, your professor cells. And here you really have this interface between between activating and inhibitory ligands and receptors that really, it's not just a, is there PD-1, PD-L1 interaction happening? It's really 50 different messages happening at the same time. And it's really the balance between the on and off signals that are going to dictate whether or not your immune system, your T cells, become activated and attack cancer cells, or if they become anergic, or they basically, fall asleep within the tumor microenvironment. And there's many different mechanisms of action of these immunotherapies that are in development. And there's, I'll show you a figure. There's nearly 5,000 agents currently in development, and they all work in slightly different ways, and they're attacking slightly different pathways. But in general, we can boil it down to stepping on the gas or taking your foot off the brake. So it's either revving up the immune system or kind of stopping some of the off signals that happen. And so, looking at this synapse, we have lots of these on signals. So these are receptor ligand interactions between T cells and APCs, and we have the sort of similar receptor ligand interactions that really turn off T cell function. And up here on the top, we've developed a variety of agonistic antibodies. So these are antibodies that will bind one of these ligands or one of these receptors, and they basically mimic binding, positively mimic binding to the cognate ligand receptor on the other cell. And so, for instance, we have a CD40 antibody that we've put a lot of patients on clinical trials with. And what happens is the CD40 antibody binds to this CD40 on the antigen presenting cells, and it tricks this antigen presenting cell into thinking that it's seeing CD40 ligand activating that APC so that the APC will activate T cells. So that's how agonistic antibodies work. Antagonistic antibodies, these are the ones that we have FDA approved in the clinic. These are really inert antibodies, and all they do is they bind PD-1 or PD-L1 or CTLA-4, and they just block the interaction of the receptor and ligand from happening. So they block that off signal from being transmitted between the T cell and the antigen presenting cell. Again, this is all about a delicate balance. It's not a black or white issue, an on or off signal. It's really a collection of many different signals. And these are the antibodies that we have that are FDA approved right now. We only have one antibody FDA approved for CTLA-4. There will be at least one more approved probably by the end of the year. And then we have 3 antibodies that we use to block PD-1 and 3 antibodies that we use to block PD-L1. So disrupting this PD-1, PD-L1 interaction. Those drugs are relatively similar, but we have drugs that are in development, in advanced stages of development, looking at all these. And this figure, I think I made this figure 2 years ago, and it's beyond outdated at this point. But these antibodies have really revolutionized the way in which we treat cancer. So this is one of the first phase 3 trials that came out. This is only 5 years or 6 years old now. So this is 2015. And this was in patients with metastatic melanoma. So melanoma was a universally fatal diagnosis. The standard of care for melanoma, metastatic melanoma, was dacarbazine, which is a terrible chemotherapy. I think particularly most of the trainees, you'll never see this ever used again because it is a very toxic chemo. It's not very effective, especially for melanoma. As you can see here, this is a Kaplan-Meier curve showing that by 18 months, just about all the patients have already died, and the median overall survival was less than 1 year. But when patients were randomized to either dacarbazine or this new drug nivolumab, which is a PD-1 blocking antibody, you see there was an amazing divergence of Kaplan-Meier curves here. And this is not something that we are used to seeing in cancer. Usually we see sort of these incremental changes. So this was obviously very exciting. This was a similar study 2 years later in which patients, at this point we got rid of the chemo, but patients were receiving either ipilimumab, the CTLA-4 blocking antibody. This was the first antibody that was approved, the first cancer immunotherapy that was approved. Patients either received ipilimumab alone, nivolumab alone, or the combination. And you can see here that we're at 3 years out here, and about 40% of the patients are still either have stable disease or they're in complete remissions. And so this is a progression-free survival here on the y-axis. And what's most notable here is that when we're looking at these Kaplan-Meier curves, we're seeing many years out. And this trial only treated people for 2 years. So they stopped the therapy at 2 years. And you see that the majority of patients are still maintaining whatever response they had for a year plus after. And when we see plateaus in Kaplan-Meier curves, what that really correlates with, we believe, is cure. And so metastatic melanoma, metastatic just about any type of cancer is considered incurable until now. And now we are starting, we're not, telling our patients we're going to cure them quite yet because we're very skittish about using the C word. But we are seeing as this data matures, and again, these studies are not yet at the 5-year mark, we are seeing more and more patients who appear to be in a very durable, complete remission, and hopefully we are curing a subset of them. So checkpoint blocking antibodies, obviously super exciting. They've revolutionized the treatment of all sorts of different types of cancer. That doesn't come without toxicity. So in general, they're much more tolerable than chemotherapy, particularly the types of chemo that we give for colon cancer and breast cancer. But they do come with toxicity. So basically, as I said, most of these antibodies, they're either taking your foot off the brake or they're stepping on the gas. And this does come with the potential for toxicity and significant, potentially fatal toxicity. And it's, some people call it autoimmunity. I think a lot of rheumatologists and other specialists they don't like that term per se, but it is, I would say it's autotoxicity. It's really from, aberrant activation of the immune system. So hopefully the immune system is attacking a tumor, but at the same time, it might be attacking normal tissue. And as I mentioned, because of the development of immunotherapies, I'm now interacting with every specialty under the sun because basically you take any part of the body and you add itis to it, and that's a side effect that we've seen. Just as an example, one of the first patients I gave CTLA-4 blockade to, she came in, she always had hypertension. She came in, her blood pressure was in the 60s or 70s systolic, and she had developed adrenalitis, which was I didn't know that was a word until I diagnosed her with that. But we're having every itis under the sun. Some of these itises, especially myocarditis, pericarditis, pneumonitis, they definitely can be fatal, especially if not recognized very early on. And so it's important when patients, I always tell patients when they're on cancer immunotherapy, if they do have something going on and they don't have time to call me, as soon as they walk in the emergency room, they just have to start screaming that they're on cancer immunotherapy. So hopefully, an oncologist can consult and help, work up any potential odd side effect, especially some of these more obscure inflammatory presentations, especially the endocrinopathies like the hypophysitis in particular can be pretty confusing, especially with all the different hormones going on there. And the mechanisms of action are pretty diverse. So, or rather the mechanisms of toxicity. So we think that most of the time it's from disruption of adaptive cellular immunity. And so it's basically from your T cells recognizing self-antigen that's being presented on normal tissue. So that initially we thought that was the etiology of all the toxicities. We also see there's some disruption of the adaptive humoral immune system. So you might see the development of autoantibodies. And I have, given checkpoint blocking antibodies to people and they develop ITP due to the development of autoreactive antibodies against platelet antigens. Similarly, just by disruption of normal vasculature or normal endothelium, such as in the case of the gut, you can actually cause inflammation, and it's not necessarily from destruction of the endothelium or the lining of the gut. It's just due to a inflammation resulting in a increased permeability of the gut, leading to sort of this inflammatory cascade that can take over and that can look a lot like IBD. And finally, you can have on-target, off-tumor activation of the immune system. So the best example of this is that when we use CTLA-4 blocking antibodies, we notice that there's a relatively high rate, which is still just a few percent, of hypophysitis. And one reason for that is that there is a pretty robust expression of CTLA-4 on the pituitary gland, one mechanism the pituitary gland has to escape attack from your immune system. And so when we use CTLA-4 blocking antibodies, the pituitary gland is more susceptible to inflammatory attack from your normal cells. And it's important to note, as opposed to chemotherapy where we give it and, we say, all right, 3 days later, that's when you're going to start feeling bad. And about 7 days later is when, your fatigue is going to peak. And 2 weeks later is when your hair is going to fall out. With, immune-related adverse events, so IREs or immune-related adverse events, they can happen at any time. And it's really important to realize this, because I've had a patient who was on pembrolizumab on a clinical trial, and he did fine for 18 months, and all of a sudden at 18 months he developed immune-related nephritis. And so in general, there's a certain window. We typically think that these side effects start to pop up around 6 to 8 weeks after starting therapy. So definitely not within the first few days. That's pretty rare. It's very rare, but it can happen. But each of these different toxicities sort of has a different window. This is obviously, looking at these curves, this is not actual data. This is just sort of an example of the general presentation that we see of these different toxicities. Certain ones show up a little bit earlier, certain ones show up a little bit later, but they can really happen at any time. And we have seen toxicity within the first few days, particularly with some of these new antibodies that are really revving up the immune system and stepping on the gas. And also important to note is that these IRAEs can happen even after cessation of immune therapy. So these immune therapies, first of all, they have a half-life of around 20 to 25 days. So they're sitting around in people's bodies for months after their last dose. And also, in many ways, they've permanently changed the immune system when we gave them to patients. And so many patients all of a sudden, might develop allergies or might not have allergies anymore. I mean, there's sort of lots of odd ways in which they alter the sort of immune homeostasis within patients, but they can also have changed things and changed certain cells so that, 8 months down the line after stopping therapy, if all of a sudden you get the flu, you might have some sort of cross-reactivity with a normal antigen because your T cells have been revved up by the immune therapy. So it's just important to always keep in the back of your mind when somebody has a history of cancer, especially now that we are, curing, especially the melanoma patients. We're probably curing about 40% of those patients. In the next 5 to 10 years, you're going to be seeing patients come in who might forget to mention that they had received 2 years of nivolumab, back in 2018, and now it's 2025 and something's popping up, and you should always keep it on your differential. And these toxicities can definitely be fatal. And unfortunately, this is a patient that I had put on a trial. This was the first patient on this clinical trial. So a very low dose of this agent. It was a immunotherapy that, as I said, it steps on the gas, so it activates the immune system. She had metastatic ovarian cancer that involved her entire right lung. It was lining the pleura, but also invading the parenchyma. But you can see that her left lung was crystal clear, and she was a never smoker, and was satting 100% just with her using her left lung. 3 days later, though, she was feeling shorter breath. She came in, she was satting in the low 70s on room air, and she had developed this rip-roaring pneumonitis on the contralateral side. And eventually she did die from complications of this, actually from infections from all the steroids that we had to use to turn it off. So they can be a little scary. They're rare, and they're definitely, these agents are better tolerated than most chemotherapies, but these toxicities are real, and these are not benign medications. And it's difficult to treat them sometimes because it's not something that can easily be tested, how to treat these things, because the presentation is very different from patient to patient. And so it's not the type of thing where, when people present, we have time to sit down and enroll them in a trial and stratify them between different therapies. In general, the first line therapy for most immune-related adverse events is just steroids. Usually we start with either 1 or 2 mg per kg daily, sort of depending on the severity. There's a variety of different guidelines that are out there. ASCO, the American Society for Clinical Oncology, SITC, ESMO, all the different organizations have guidelines. They're all very similar. And usually they also encourage you to do biopsies and try to work up any other etiology for the side effects that you're seeing. Endocrine immune-related adverse events are the one exception, where we oftentimes won't bother using steroids because by the time that you're having symptoms, usually the ship has sailed, and if you've developed immune-related pancreatitis that results in type 1 diabetes, all of your islet cells at that point have already been destroyed, and so you just have to at that point deal with the sequelae. Oftentimes we'll have to do hormone replacement therapy, especially hypothyroidism is not uncommon. And for severe immune-related adverse events, now we're also using concomitant biologic therapies. And this is just one example of the different therapies that we might use. Oftentimes we will patients have very severe colitis, for instance, we'll always try to get a biopsy, hepatitis similarly. And there is some recommendation of the different biologics to include with steroids if steroids are not enough. This review sort of gives you a recommendation based on the immune infiltrate and the type of inflammation that you're seeing. So for instance, if you have a predominant T cell infiltrate in these patients along with steroids, we oftentimes will use tocilizumab, which now we're all very familiar with given the excessive use in COVID early on, or the IL-1 blocking antibodies. If you have a predominant neutrophil or monocytic infiltrate, like we usually will see in the immune-related colitis, it looks very similar to the colitis that we see in IBD. And so we'll oftentimes use TNF blockade in those patients as the first line therapy. And then similarly, it's a little bit more rare, but if you see a plasma cell or B cell infiltrate, or you think it's a antibody-mediated toxicity, you might use a B cell targeted therapy with or without IVIG. So that's all I have to say about the toxicities, but always happy to talk more about that and help guide any therapy if you guys are seeing odd toxicities. But really, the research that I focus on most right now with the development of new therapies is really on improving the success that we've already had. So this is data that was updated, I think in the fall, that looked at the combination of chemotherapy with pembrolizumab, a PD-1 antibody, compared to chemotherapy alone in metastatic lung cancer. So this curve, every time I see it, it makes me super happy. I'm a lung cancer doctor on Friday mornings. That's my quote unquote normal patient time. And so Friday mornings, I see these lung cancer patients. We give them pembrolizumab with chemotherapy, and many of them go into very nice and potentially very deep remission. So here, when we added pembrolizumab to chemotherapy, we increased the median overall survival from less than a year to nearly 2 years. And so we're more than doubling the median overall survival, which is amazing. It's literally doubling the size of our lung cancer clinics. And we're giving people a lot more time. And some of these patients are actually achieving a complete remission and staying in remission. But whenever I see these Kaplan-Meier curves, while I think that they're super exciting, obviously the elephant in the room is what's happening to the majority of patients who, even if they initially may derive some benefit, their cancer eventually will progress and they will eventually die of their disease. So what do we do with these patients? So going back to this overly complicated figure, I always like to show just sort of to emphasize the complexity and all the different ways in which we can potentially target the immune system. And unfortunately, we don't yet know how to, do a biopsy of a patient's tumor and look for biomarkers that would say, all right, this patient should receive a CD40 antibody versus this patient should receive a PD-1 blocking antibody. But that really is one of the focuses of most of the trials that we're doing, where we're always getting lots of biopsies and blood samples so that we can hopefully learn from our successes and from our, unfortunately, more common failures. But like I said, the only antibodies that we have that are FDA approved really target this tiny little subset of the immune interface with the tumor and the immune priming apparatus outside of the tumor and the draining lymph node. But we have trials that are looking at all these different agents in the synapse. We're looking at a variety of different cytokines. Some of you older folks listening might have a memory of some of the first cancer immune therapies that were developed in the 80s and 90s, where we were using high dose IL-2 and to an extent interferon. These therapies were extremely toxic. High dose IL-2 was only administered, I don't know if we ever gave it at Sinai. It was in general only administered in the ICU, and you basically just slowly titrated the dose until you almost killed someone, and then you backed off a little bit. And that's not an exaggeration of how they decided the dose to give people. But it did cure about 5% of people with melanoma or renal cell carcinoma. So, but now we have a variety of cytokine therapies that are much better tolerated and much more targeted to the cells that we're trying to activate, so slightly more intelligently designed. We have therapies that are targeting the metabolic milieu, so IDO and a variety of metabolic the sort of metabolites within the tumor immune microenvironment and the draining lymph node that kind of skew T cells one way or another towards being Tregs or senescent versus being activated. And then also therapies targeting T regulatory cells. And then a lot of the work that we do, because Mount Sinai has they're really world leaders in myeloid biology, is finding different ways to modulate the myeloid cells, including the macrophages and the granulocytes within the tumor. And I mentioned this earlier, but this field is growing very quickly. This is a report that's put out by the Cancer Research Institute, which is a nonprofit downtown that funds a lot of our research and other research in cancer immunotherapy. And the CRI sort of regularly updates the number of agents in development, just so we can see the direction the field is going. And this is an update from the fall of 2020 that even despite COVID, we saw a significant growth from 2019 to 2020. And we have nearly 5,000 agents in development right now. And so this is super exciting as a trialist. I have about 30 of these in clinical trials, and they it's definitely exciting to have a lot of new tools in the toolbox. But the problem is we don't necessarily know how to use these tools and what the smartest way to do that is. And that's really what a lot of my research focuses on, because there's some very central questions that we have to answer before we can use all those fancy new tools. Number one is how these agents work in vivo. So we're giving pembrolizumab and nivolumab out like water at this point. There's an indication in just about every cancer type, at least for a subset of cancer patients. Even in breast cancer and prostate cancer, we are using it in a subset of patients. We don't know how these drugs that are FDA approved work in humans. We know how they work in inbred mice. But we are not inbred rodents. We are a very heterogeneous population, particularly here in New York. And I think the lack of efficacy in most of our patients really underscores our lack of understanding of the heterogeneous response and how we can identify who will benefit and who will not. And biomarkers are a really important thing to predict, what drug should we give to what patient or what combination. And when it comes to combinations, we don't know exactly what targets we should use potentially in combination with PD-1 blockade. So oftentimes, two drugs are tried in a clinical trial. Just because a drug company happens to own those two drugs doesn't mean that it's the best combination. So like I mentioned, we have nearly 5,000 agents, but one of the biggest issues that people rarely realize is that even though it seems like cancer is a growing problem, which it is with the aging population, we actually have too many agents to run all the clinical trials. We don't have enough patients to put on all these clinical trials. That really results in, oftentimes we'll open up phase 2 trials to see whether or not something works, and we won't even be able to fill those trials, which is really a disservice both to our community, but also most importantly to our patients. And like I mentioned, a lot of the times we're just sort of throwing spaghetti at the wall and seeing what sticks. So, Bristol Myers Squibb owns nivolumab and ipilimumab, so they've taken that combination and just put it in everything under the sun and see where it works. And most of the time it is not successful, unfortunately, even though I don't think it's an irrational combination. But our answer to all of these questions is really to take a step back and do a deep dive trying to understand, the immune microenvironment within tumors at baseline, so not treated, and then also do very small clinical trials where we can rapidly accrue to the clinical trial, and then do a very deep dive scientifically to try to understand what is it this new drug X is doing within humans. And the way in which we do this is we do what we call deep tumor immune phenotyping, which is basically just using lots of new single cell and multiplex technologies to understand the complexity of the immune system within tumors and between tumors within different patients, so that we can better understand the baseline immune system and also what these drugs are doing, what the dynamic changes are that are happening, so that we can better understand how to use them. So we have a variety of technologies that have been optimized, oftentimes here. Our immune monitoring core is really one of the best in the world. They have a multiplex platform, which is called Mix, that was developed in-house, where you can take a single section of tissue, and instead of looking at just one marker like CD20, for instance. If you're looking for B cells here, you can look at 10 different markers, so you can really understand the complex 3D interaction between your immune cells and the stromal cells and the tumor cells, so that we can better understand how to perturb those interactions and get your immune system to recognize and kill the T cell, or the tumor cells rather. We have another multiplex platform called MIDI, which uses antibodies that are tagged with heavy metals. This can actually look at, it's typically smaller sections, but it can look at up to 50 different markers on a single section of tissue. And we're currently working to optimize this new technology called spatial transcriptomics, where with near single cell resolution, hopefully we'll be there within the next year or two, we can actually look not only at the protein on the individual cells and identify this is a B cell, this is a T cell, but we can actually look at the transcriptomic signature of those cells. So looking at a T cell and saying that CD4 doesn't tell us a lot about its functional capability, only by looking at the transcriptomic signature. Transcriptomic means we're looking at the RNA within those cells. By looking at the RNA, which gives us an idea of what protein is in the cells, we can actually get an idea of activation status. So we can see, is this T cell activated and actively killing the cell right next to it, or is it a exhausted cell? Exhausted cells, this is an actual term that we use. It basically just means the cell is turned off. It came into the tumor, and because of a variety of the factors that I've been talking to you about, it basically falls asleep and is not doing anything. And so we want to know about the functional status, and we can only do that by looking at the RNA. And we also have a variety of single cell technologies, and these have really been pioneered by researchers here at the Immune Monitoring Core right outside my office. And these include CyTOF, which is mass cytometry. It's basically like flow cytometry that I think we all had to learn, at least for our board exams. Flow cytometry usually can look at about 5 to 10 different markers on a single cell suspension. With mass cytometry, we can look at around 50 different markers. And these single cell technologies really allow us to resolve very small populations. So again, instead of just looking at CD8 T cells, we can look at 15 different sort of subsets of CD8 T cells, stem-like CD8 T cells, central memory cells, effector memory cells, all these different subsets that are very important at modulating the immune reaction. And it's most important to resolve all these different populations because we want to very precisely target them so that we can activate the cells we want to activate or inhibit the cells we want to inhibit, as opposed to just using, sort of a sledgehammer approach and activating all T cells, which is what that high dose IL-2 that I mentioned earlier really did, where it activated the effector T cells, but also your T regulatory cells. So the net, gain was 0. We have single cell RNA sequencing, so we can take each individual cell and look at all of the RNA within each individual cell, and we can look at the single cell transcriptomes of hundreds of thousands of cells. CytSeq is basically the best of both worlds. It's mass cytometry and single cell seq together, so you get all this proteomic data and transcriptomic data from individual cells. And I'll show you some examples of why that's useful. And we're right now publishing the first CytSeq analysis of human tumors that's ever been done, which is in early stage lung cancer, which will be an exciting step forward. And then PIC-seq and ATAC-seq are just other single cell technologies that we use just to learn as much as we can about these individual cells. So how do we use these technologies? So we've been using these for a while now, initially looking at treatment naive tumors. So as was mentioned, I really focus on lung and liver just because we have a lot of lung cancer and we have a lot of liver cancer. We have the largest liver cancer program outside of Asia. And so what we've been doing is we basically will cut out a tumor. When you cut out a tumor, obviously you have your margin. And so we will take the tumor cells, we'll take the adjacent cells, which we call the normal cells, although obviously these are most of these cirrhotic livers, so they're not normal livers. We may take the draining lymph node if that comes out with surgery, and we'll also take peripheral blood. And we'll use all of these mechanisms to analyze it and really just phenotype what does the immune system look like at baseline, because it's really important to have a baseline before you try to, perturb things. But then we can perturb things potentially with, one of these new immune therapies like a PD-1 antibody. And by doing biopsies beforehand, and then we cut the tumor out after, we can see what happened. And that really is the focus of what we call window of opportunity trials or neoadjuvant trials, where we're giving therapy before surgery. And these window of opportunity trials, basically what happens is we have a patient, for instance, an HCC patient, We do some high resolution imaging so we can understand the vascular architecture and how much of the tumor might be necrotic or inflamed. We get blood, we get stool because we're looking at microbiome, and we do a bunch of biopsies so that we have some baseline idea of what the immune infiltrate is in the tumor. Patients then get a very short period of therapy. So these is not delaying surgery that much. So usually it's anywhere from 2 to 6 weeks of this therapy, and then they go to the operating room. We usually will do repeat imaging right before they go to the OR, not only to see what happened, but also to help guide the surgical planning. We get some more blood, we get more stool, and then we obviously get the biopsy. So this is very exciting because it's sort of giving us a dynamic picture of what happens with these therapies. But it's not, I always want to emphasize, we're not experimenting on these patients. I think for the patients, this is an amazing opportunity for clinical benefit. So in these patients that are going to the operating room, these patients have an intact immune system. So they haven't gotten, cytotoxic chemotherapy. We never use chemo for liver cancer, but for, breast cancer or lung cancer, they haven't gotten chemotherapy. So their immune system is intact. So they probably have a higher chance of response. They have smaller tumors, and we know immune therapy, sort of the effect indirectly correlates with the tumor mass. So smaller tumors are going to likely respond better to immune therapy. There's less heterogeneity and less loss of heterozygosity. So there's more likelihood that if the immune system recognizes the tumor, it can kill the whole tumor as opposed to just little subsets that have certain antigens. So we think that and this is based on the trials that are coming out in colon cancer and lung cancer, we think there's definitely a higher chance of cure with immune therapy in the perioperative setting than when patients already have metastatic disease and they basically have lots of different types of tumors throughout their body. So I think that it's a real boon for patients. And I think that, in the next 3 years, we're probably going to see lots of FDA approvals for neoadjuvant immune therapy, not only in breast cancer, which will be the first indication, but also likely later this year or early next year in lung cancer, we'll also see this become the standard therapy. But for research purposes, a scientist, I'm super excited about these trials because they're going to allow us to finally define mechanism of action of these drugs where we're still kind of clueless of how they work.
It's cancer immunotherapy. It's.
I think somebody is not on mute.
I'm muted here. That's fine.
Okay. It'll allow us to define some biomarkers to say, which patients should get what therapies. We can do much smaller trials. So we're not doing, a 500-person trial and then realizing it doesn't work. We can do, a 10 to 20-person trial and see what's working and what's not working. And additionally, it'll allow us to propose rational combinatorial approaches. So it'll tell us we should be combining pembrolizumab with radiation or with this new immune therapy, as opposed to the unfortunate reality, which is oftentimes throwing spaghetti at the wall and seeing what sticks. So it's I think by learning how these drugs work, we can combine them in a much smarter way, hopefully. So this is the first neoadjuvant trial that we had opened in June of 2019, so almost 2 years ago. And there's 3 different cohorts here. We had 3 different lung cancer cohorts, liver cancer and head and neck cancer. And patients receive a few cycles of immune therapy and then they go to the operating room. In lung cancer, you can see there's these 3 different cohorts. So one group receives immune therapy alone. One group receives immune therapy and chemotherapy, and one group receives just chemotherapy. And the reason for this is, I mentioned earlier that our standard therapy for lung cancer now is a combination of chemotherapy and immunotherapy. And when I first heard about that being tested in a clinical trial about 5 years ago, I think most immunologists thought that was a horrible idea because one of the therapies is waking up your immune system and activating your T cells, while the other therapy is cytotoxic, it's lymphotoxic, and you're giving high doses of dexamethasone as an anti-nausea med with the chemotherapy typically. So it's like you're revving up your T cells and then you're going to kill them off with the steroids and the chemo. And obviously I was totally wrong, as were we all, because it does seem like I think that there is some synergy. There's definitely not the antagonism that we thought there might be. So here we're really trying to do a deep dive and try to understand the different components of chemotherapy and immune therapy and see if we can potentially more intelligently combine them. It might make sense to sequence them instead of give them at the same time. We don't know. So that's one of the goals of this trial. As I mentioned, we get a lot of biopsies, stool, blood, high resolution imaging beforehand. We get a lot of blood throughout. We go to the operating room and we get the tissue. So this trial is underway. We actually already completed accrual to the HCC cohort. The last patient went to the operating room in December. And so there's actually, we have 2 oral presentations at AACR in April, where we'll be showing some of the data from this. I can't show it to you yet, but it's pretty exciting what we're seeing. And I think that we will be seeing some additional cohorts very soon. And this is all the analysis I had sort of mentioned before. We're really looking at everything under the sun to try to understand what it is that is changing when we are giving these therapies. That's the beauty of having a very small trial, is that we can do, as I said, a very deep dive and a very exhaustive analysis of all the biospecimens to try to understand what the changes are and how we can potentially even improve on what we already have. So the goal here, so we have this established analysis pipeline I talked about, where we're looking at tumors and we're looking at the neighboring cells in the blood. And the goal is really to develop an adaptive trial design. And that's what the trial I just showed you is planned as an adaptive trial design, where what we're doing is we're constantly learning from our in-depth analysis of human lesions, initially, treatment naive. And then what we do is we bring what we learn back to the laboratory. We improve upon our preclinical mouse models, and then we use what we learn from humans to try to model and identify different therapeutic approaches. We test out those therapeutic approaches in mice, and then we bring those therapies back into humans. And the goal here is I'm not a phase 3 doc. I'm not trying to bring something to market. But it's more about constantly doing small clinical trials and reinforming our preclinical models and moving the field forward as quickly as possible in sort of this adaptive cyclical manner. And I'll tell you one anecdotal report of the way in which we're doing this sort of adaptive informed trial design. The first analysis that we published of treatment naive tumors, of single cell analysis, this was back in 2017. Yonit was a MSTP student in Miriam Murad's group, and she published this very nice paper in Cell, in which she took early stage lung tumors. They cut out the tumor, they cut some of the normal tissue, and also they took paired blood at the same time of surgery. They made single cell suspensions, and then they analyzed this using myeloid and lymphoid panels on the mass cytometry. So once again, this is a technology that's basically like fancy flow cytometry, where you can look at 50 different markers. We actually looked at 100 different markers because we had 2 panels of around 40 to 50 different markers in each panel. And what this allowed us to do is really compare the tumor to the neighboring normal lung, quote unquote normal lung. Most of these patients are smokers, so their immune system's not normal. But it really allows you to see what is unique within the tumor. And so there are certain things that we would expect. So red means more prominent in the tumor compared to the neighboring tissue. So one thing that we would expect to see is that there's an enrichment in T regulatory cells, which are the T cells that kind of turn off your immune system, as well as the exhausted PD-1 positive CD4 and CD8 T cells. So we have lots of exhausted T cells and T regulatory cells. But interestingly, one thing we noticed is that the number of macrophages were relatively equivocal in the tumor and the neighboring normal lung. We know there's a lot of data out there that macrophages are bad for within the tumor. They basically play a very inhibitory role on the immune microenvironment. So we were surprised that there were basically the same number of macrophages. But what we realized is that when you looked at the macrophages from the normal lung, which are predominantly alveolar macrophages, which we all know are the tissue resident macrophages within the lung. If you compare the alveolar macrophages to the macrophages within the tumor in orange here, you see that at the transcriptomic level, they have a very different phenotype. And so the macrophages within the tumor are very different from the alveolar macrophages. And we also see that the number of these macrophages, we call these monocyte-derived macrophages because they're not the tissue-resident macrophages, so they must be from monocytes that extravasate out of the blood into the tumor and differentiate into macrophages. The number of these monocyte-derived macrophages correlates perfectly with the number of T regulatory cells or the number of exhausted CD8 or CD4 T cells, or also exhausted NK cells. And so it seems like this is just a correlation, but it seems like the presence of these cells correlates with the degree of the immunosuppressive immune microenvironment. And we know, the fact that as I mentioned, we know that there's a lot of data demonstrating that having a lot of macrophages within a tumor is a bad prognosticator. And this has been shown, this is from Yonit's paper from TCGA analysis in early stage lung cancer, but it's been shown in just about every type of cancer other than maybe colon and prostate cancer, that having a transcriptomic signature that demonstrates a lot of macrophages within a tumor, so the blue line here, it portends a worse overall survival. So the problem, though, is that not all macrophages are the same. So we can't just talk about macrophages, and this sort of goes to my focus on the granularity and resolving these individual small populations within a large immune population like macrophages. We already knew that there's a slew of different macrophages. As I mentioned, there's your alveolar macrophages, which are your tissue resident macrophages that live within all of our lungs and help maintain homeostasis. There's these interstitial macrophages, which play an odd role, likely are involved in some of the fibrotic diseases we see in the lung, but also play a role interacting with nerves. And we're still kind of learning about what it is that they do. They don't seem particularly involved in the development of lung cancer. But then there's these monocyte-derived macrophages, monomacs that I mentioned, where monocytes from the blood extravasate into tissue, and they're actually recruited into growing tumors, and they turn into these monocyte-derived macrophages. So we have all these different types of macrophages, but a lot of the therapeutic approaches looking at macrophages have focused on targets such as CSF1R. And so CSF1R, colony stimulating factor 1 receptor, is expressed. It is, if you block it, it definitely will deplete macrophages, but it's basically expressed on all myeloid cells. So not only is it expressed on monocytes and macrophages, it's also expressed on dendritic cells, particularly these CD141 dendritic cells. And I mentioned this earlier, but these are the antigen presenting cells, the professor cells that are, you could say they're the smartest professor cells of the immune system. They're the ones that are most potent cross presenters of antigen, the ones that are going to teach the most CD8 T cells how to be killer cells, how to get rid of cancer. And we know from a trial, a preclinical trial here at Sinai, and this was published in 2016, basically at the same time as 4 other papers showing the exact same thing, that this is a melanoma model in mice, and if you give PD-1 blockade, the cancers do slow down in their growth potential, but if you get rid of the DC1s or the CD141 dendritic cells, you lose all benefit from immune therapy. So these dendritic cells are absolutely important for the ability to respond to pembrolizumab or nivolumab. And if you were to block CSF1R and get rid of all of these types of cells, you basically are getting rid of the good guys and the bad guys. And so, you're throwing the baby out with the bathwater. And when we are doing these non-targeted therapeutics where you're just getting rid of an entire collection of cells, whether it be macrophages or a certain type of T cell, you're not doing it in a precise way. Evolution has developed that heterogeneity or the complexity for a reason. And if we ignore that, we're really never going to see benefit. And that's what we see. CSF1R, they've probably spent $1 billion across 15 different companies developing antibodies to this, and every one of the trials has been a failure. So our focus is really to try to better understand the granularity. And I'll skip forward a little bit just to give you the punchline, is that we have been doing this analysis site-seq where you get some RNA data and protein data from individual cells. And when we look at the macrophages, these monocyte-derived macrophages within the tumor, so everything here above the red line represents a cell that's enriched in the tumor. If it's below the red line, it represents a cell that is enriched in the normal lung that is neighboring. We see that there's these subsets of cells, these monocyte-derived macrophages, that are really only seen in the tumor. And if we look at their transcriptome, we see that they're very immunosuppressive, and they secrete lots of cytokines that really turn off the ability from your T cells to kill the cancer. So we think that these little subsets of monocyte-derived macrophages, not even all monocyte-derived macrophages, just these 2 subsets, are really the ones that we want to focus on. And in order to identify a good therapeutic target, we basically took this data back to the lab, and we have a mouse model of lung cancer. It's a KRAS mutant P53 deficient lung cancer model. And here we see a very similar population that sort of correlates with those monomac populations that expresses very high levels of CCR2. So these are inflammatory monocyte/monocyte-derived macrophages. CCR2, or chemokine receptor 2, is a receptor that is on these cells that is very important for the recruitment and retention of these macrophages or these monocytes out of the blood into the tumor, where they differentiate into these bad guys. So what did we do in the lab? We looked at a CCR2 knockout. And if you look at the CCR2 knockout, you're not getting rid of all the macrophages. You're just getting rid of these inflammatory macrophages, these Ly6C high macrophages. And if you then instill this KP lung cancer model in these mice, we see that in the knockouts, they all of a sudden, they're not really developing cancer, at least not at the same rate as they were in the wild type mice. So it seems like the lack of recruitment of these macrophages to the lung really stymies the development of lung cancer in this lung cancer preclinical model. So we see this preclinical finding. So we basically saw something in humans, we bring it back to the lab, and then our goal is always to bring it back to the humans, like I mentioned, and that's exactly what we've done. So based on this data, we went to our colleagues at BMS who have a CCR2/5 inhibitor, and we developed this clinical trial, again, in lung cancer and liver cancer. And it's a neoadjuvant trial that is very similar to the other one that I showed you, that basically what is happening is patients are getting a combination of a PD-1 antibody and either a CCR2/5 inhibitor, or another cohort will get an antibody combination with an anti-IL-8. So this blocks the recruitment of neutrophils, or the sort of the immature granulocytes, which are a different type of quote unquote MDSC, myeloid-derived suppressor cells. So these are basically two different ways of blocking recruitment of two different bad guy myeloid cells to the tumor. So two different ways that the immune system is turning off the ability for your T cells to recognize and kill cancer. So we have this clinical trial ongoing right now. This is our funding source for a lot of the analyses that we're doing. And I don't have any data to show from that yet, other than I'll show you from the first patient. This is just blood analysis. We gave the CCR2/5 inhibitor. And as I mentioned, chemokine receptor 2 is very important for the ability for monocytes to leave the blood and go into the tumor. It's also important for the ability for immature or early monocytes to leave the bone marrow and go into the blood. So basically, once we gave this patient, in orange here are the inflammatory monocytes, the CD4 T monocytes. Once we gave them the CCR2/5 inhibitor, the number of monocytes in the peripheral blood dropped precipitously, because basically what was happening is we were sequestering all of these monocytes in the bone marrow. So not only did they not get to the tumor, they weren't even going into the blood. But then as soon as we stopped the drug, you see there's this kind of rebound where all of these cells eventually leave the bone marrow and go into the blood. So we think this is a little bit of an initial proof of principle. Obviously, the most important thing is going to be to look at the tissue that we resected. So finally, the neoadjuvant space is super exciting. We're doing a lot of different trials, but unfortunately, we can only use agents or combinations that have significant safety experience, because we don't want to, give somebody side effects that'll make it so they can't go to the operating room. But unfortunately, a lot of our phase 2 trials, proceed without an understanding of the mechanism of action. So now what we're doing is we're actually incorporating all these technologies into early phase trials, into first in human trials even, so that we can better understand how these new drugs, those 5,000 drugs that I just told you are in development, how they work from day one, using the same sort of approach, which hasn't really ever been done before in early stage trials. So in summary, this is our approach. It's really this adaptive design where we're trying to learn from humans, bring it back to the lab and bring it back to humans, and repeat this as quickly as possible, so that we can continue to see improvement in these curves, and hopefully get all of our patients into remission and keep them there. So the research I showed you, this is just a small sampling of the people involved. There's well over 100 people involved in these trials that are very complex, both on the clinical side, in the operating room, in pathology, and then in the laboratory here. So I owe lots of gratitude to them. Most importantly, Miriam Murad, who's the head of our immune monitoring core and one of my closest collaborators and mentors, and Marron Schwartz, who leads our liver cancer program, who's a phenomenal surgeon and a physician scientist as well. So with that, I know there's just a few minutes. I'd love to take any questions. Also, there's my contact info. Always feel free to reach out if you have any questions about our new drugs.
Thank you very much. It's a great talk. So much I didn't know. So if anyone has a question, please identify yourself. You can unmute yourself, say where you're from, where you work, what kind of patients do you see, and then pose your question. I think we have time for 1 or 2 questions only.
I do have a question.
Yep.
Yeah. Hello, I'm Paulino, one of the PEY2s of internal medicine. I actually had two main questions. So for the neoadjuvant trials that you were mentioning, I mean, you're mentioning that maybe in the neoadjuvant setting, that maybe you may have a higher response because you're maybe priming, like maybe you're increasing the T cell priming. I guess that the hypothesis. I just wanted to ask you if you look also at circulating cells. Like many of these agents, like TIGIT, also PD-1, can also have a significant impact on NK cells. And NK cells are supposed, at least in mouse models, to be more effective in controlling circulating cells and controlling metastasis. I was wondering if you look at it, if you had any readout regarding NK cell activation and whether that is doing some kind of anti-metastatic effect. And my second question was about CSF1 blockade. We published, I think like 2 or 3 years ago, that in mice, when you block it, CSF1, you get, which is actually the same thing that you show, you see a decrease in circulating monocytes. And what happened, what we discovered is that these circulating monocytes have to transpresent IL-15 to NK cells. So what we were showing is that the NK cells in the circulation will go down, and then mice will paradoxically get more metastases because of lack of NK cells. So my question is whether in the trial where you are blocking CCR2, you measure circulating NK cells in humans and whether you saw a decrease.
So that's both good questions. So we are doing analysis on the blood. So we're doing mass cytometry on the blood as well as O-Link, which is basically like ELISA, but looking at 96 different analytes. And we're definitely interested in looking at NK cells, especially in the liver. The liver is actually one of the largest reservoir of NK cells. And so it'll be very interesting to see if we are having an impact on the NK cells. And obviously we don't want to be depleting the NK cells by depleting the myeloid populations, although we are using the CCR2 inhibitor only for a short 28-day period. So the goal is really to deplete and allows for a priming of a T cell response, and then you go to the OR, and after that, they don't get additional CCR2 blockade. As far as the analysis of we're not looking, I don't know if you were referring to, when you're talking about the blood, looking at circulating tumor cells. We are collecting a lot of blood, so it may be possible to look at those. It's tough to really understand how the immune system is modulating those, biologically, just looking at the blood. And so we have a lot of peripheral blood. We can look at the CTCs. We are looking at the ctDNA because obviously we want to, sort of use that to track response and, obviously recurrence post-op. But it is tough to study those CTCs and understand exactly the interface between the immune cells and them.
I'm Norma Braun, pulmonology. Obviously, lung cancer is a big problem, but maybe I misunderstood. But it seems to me that and I want to know if it's true, that if a candidate is not a surgical candidate, they're not candidates then for any of this type of therapy, because it seems part of the protocol is to be able to sample and then remove and so on. So that leaves a fairly large group of patients who are then not qualified to fulfill the criteria for the study. Is that correct?
That is correct. Well, for these studies, so I lead our phase 1 program. So I have 50 other trials that I can put lung cancer patients on. But these trials, it doesn't. That said, for the IL-8 combination, for instance, I actually have the clinical trial. That's a multi-site clinical trial looking at a combination of nivolumab and anti-IL-8 in lung cancer patients who have progressed on first-line therapy. But if patients have unresectable disease, in general, we do have a few clinical trials looking at the first line, but in general, our first line gold standard therapy for unresectable, whether we use chemo RT or if it's widely metastatic disease, we typically are using chemoimmunotherapy in both those populations, and then they only really are referred to me for clinical trials of these novel agents once they progress on the standard therapy. But all of them, unless they have some sort of underlying, inflammatory disease or autoimmune disease, they're all getting immune therapy.
Are there any clinical comorbidity criteria which also eliminates them from any trials?
Yeah, so in general, most of our clinical trials, you have to have a good performance status. So
Okay.
there's this ECOG stratification, and people have to be pretty functional. We don't want to put very sick people on, and that is both based on performance status, but also if they have certain laboratory abnormalities, if they have chronic kidney disease, et cetera. And that's not us trying to be mean. It's really just to protect the patients, because then if they have if they get sicker, we don't know, is the therapy causing the toxicity, or is it just their own comorbidities sort of progressing. So there are some pretty standard inclusion and exclusion criteria for all the immunotherapy trials, actually all of them. You're excluded if you have any history of autoimmunity or a variety of inflammatory diseases, whether or not you classify them as autoimmunity. And the reason for that is just that there is a very high likelihood that these immune modulators may actually exacerbate their underlying.
Unknown caller.
So there are clinical trials. We have one, and they're in the cooperative groups. There are clinical trials looking at the use of immune therapies in patients who have, rheumatoid arthritis or inflammatory bowel disease. Just because if those patients get lung cancer and they progress on their first line chemo, at that point you're kind of between a rock and a hard place, and you kind of roll the dice and run the risk of exacerbating their Crohn's disease if it means that you might actually be able to put their cancer into remission. But we always recommend when people are doing that, and I do this, is working very closely with their rheumatologist or gastroenterologist or whatever their specialist is for their underlying disease, so that you can make sure that if there is any sort of flare, you can control it very quickly.
Dr. Marron, I want to thank you very much for really a wonderful talk. I will share with you, one of my colleagues texted me during your talk, and among saying what a great talk it was, he said, and he explains it all better than anything I've ever heard before. So I think I probably speak for the entire audience saying that we're delighted to know that you're doing this work, and thanks so much for sharing with us all of your insights.
I appreciate it. Thanks so much for having me, guys. And once again, feel free to reach out. I'm always happy to chat science with patients.
Thank you.
Thank you very much for coming.